Welcome to Pomegranate Case Reports, a series developed by trainees of the Royal Australasian College of Physicians. Associate Professor Stephen Bacchi from Adelaide will be hosting this chat with a neurologist who conducted a complex workup following a referral for diplopia. The 58-year-old patient had actually started out in the haematology department, where he was diagnosed with acute myeloid leukaemia and initiated on chemotherapy. No spoilers just yet, but I'll provide a link to the report published in the Journal of Neuroimmunology in April 2023.
Hi everyone, I'm Stephen. I'm a neurology registrar at the Lyell McEwin Hospital, and today I've got with me Dr. James Triplett, who's a neurology consultant and neurophysiologist at Flinders Medical Centre. Thanks for joining us, Dr. Triplett.
Thank you, Stephen. Thanks for the opportunity.
So today we'll be going through a case in a question and answer manner, aiming for a generalist audience and trainee relevant content. So to start off with, we have a 58-year-old male. They've presented with features of disseminated intravascular coagulation, or DIC, and leukocytosis. And they then are diagnosed with an acute myeloid leukemia, or AML. So AML has a monoblastic morphology and high-risk cytogenetics. Now at this stage, they've got no symptoms of central nervous system involvement, and they're not going to have a lumbar puncture because of their DIC. And they go on and have induction chemotherapy with cytarabine and daunorubicin. And they can proceed to have consolidation with high-dose cytarabine. So now we have a fair likelihood of having neurological features arise in this case, since we've got a neurologist with us, although they haven't yet developed. So thinking ahead, Dr. Triplett, are neurological side effects common with chemotherapy? Which agents are classically associated with neurological side effects?
Unfortunately, some of the more commonly used chemotherapeutic agents are associated with neurological side effects. Now, these can range from mild sensory disturbance to more profound sensory motor peripheral neuropathies. And this whole category of side effects is termed chemotherapy-induced peripheral neuropathy. And it often occurs in the hours to days after drug infusion. And in some studies is reported in up to 70% of patients within 1 month of completing chemotherapy, with 30% of patients having ongoing symptoms thereafter. Some of the therapies associated with chemotherapy-induced peripheral neuropathy include some of the platinum-based agents, taxanes, as well as vinca alkaloids and thalidomide analogues. In more recent times, the use of immune checkpoint inhibitors has also led to widespread autoimmune symptoms, and including those is peripheral nerve symptoms, and they can either be sensory or motor predominant and even mimic Guillain-Barré syndrome.
Thank you. So now the case is progressing. So we're 9 days down the track now, 9 days after the first cycle rather, and the patient has developed new symptoms. And they've developed painless diplopia and ptosis. And the physical exam findings are indicative of a right third nerve palsy. So, Dr. Triplett, in general, what's your approach to a patient with a new third nerve palsy? And how does your approach differ if, say, the pupil is involved or spared?
So the first part of the approach is to determine from clinical history, is it painful or painless? That can give some clues as to what a possible etiology is. And then actually, obviously, assessing the patient clinically and determining what the position of the eye is. It should typically be in a down and out position with impairment of adduction, elevation, and depression of the eye. And then there should also be a degree of ptosis involved. The next part is, and what you're asking about, the pupillary involvement is there an enlarged unreactive pupil? If the pupil is enlarged and unreactive, it suggests that there's been injury to the parasympathetic pupillary fibers. Now, the parasympathetic pupillary fibers are located peripherally in the nerve, and they're generally more likely affected by external compression as opposed to injury to the third nerve itself. There's actually a secondary blood supply as such that supplies those fibers. So if we see an enlarged and unreactive pupil, concern is for a compressive lesion. The causes and initial workup of these from this point of view, again, is it painful or painless? If it's painful, may be suggestive of a vasculitic phenomena, or if there's severe headaches, we may need to think of other causes. And then the next steps can include MRI of the brainstem as such, and also looking at the cavernous sinus, making sure with the imaging that we do a angiogram to assess for any aneurysm, particularly a posterior communicating artery aneurysm, which can compress the nerve as well.
Great, thanks. So third cranial nerve palsy, key things for a trainee to think about is whether the pupil's involved or not and whether there's pain or not, with differentials including intracranial cerebral aneurysms and vasculitis, including giant cell arteritis, can present atypically. So now we're going further down the track. So now we're getting to the realm of something that you might get in a short case for your physician training exams. So we're now up to day 12, and they've now got a painless right fifth, right seventh, and the left third nerve palsy. So I'll just say that again so everyone can think about it. So we're up to day 12 now, and they've got a right fifth, a right seventh, and the left third nerve palsies. So this changes our formulation significantly. Would it be fair to call this a multiple cranial neuropathy? I imagine this is going to invoke a slightly different set of differential diagnoses.
Yeah, I would agree that this is certainly multiple cranial neuropathies, or another way of terming it would be mononeuritis multiplex, where we have nerves, both left and right-sided nerves involved, and painless. The differential for mononeuritis multiplex or multiple mononeuropathies is relatively broad, and again has to be taken in the clinical context. Okay, so in this circumstance, you would be wondering about whether there was leukemic involvement, the direct tumour involvement as well, so lymphoma or another metastatic malignancy. These have also been reported in systemic autoimmune conditions, likely associated with the vasculitic phenomena, including lupus, and also with paraneoplastic syndromes. Other causes can include sarcoidosis. Sarcoidosis, though typically when affecting cranial nerves, for some reason has a predilection for bifacial palsies as opposed to this patchy process we've seen thus far in this case.
All right, so that's brought a number of other considerations into the front of our mind. So now we're going down the track again slightly further. So we're up to day 17 now, and they've developed further neurological features. So now they've developed left radial, ulnar, and perineal neuropathies. So at this point, they receive nerve conduction studies, and these demonstrate a conduction block along the left ulnar nerve, and it's at a non-compressible site in the forearm. And then the perineal neuropathy is also demonstrated on nerve conduction studies. So now we have non-cranial nerve involvement as well. And in this case, there's conduction block, and it's at a non-compressible site. So could you please explain to us what conduction block is? And what's the significance of that occurring at a non-compressible site?
And so conduction block is one of many pieces of information we can gather from nerve conduction studies. The basic principles of nerve conduction studies is to generate giving an electrical impulse over a nerve, either sensory or motor. Now, in this case, we're talking about a motor nerve, the ulnar motor responses, and we're trying to generate a motor response, or a compound motor action and potential, or CMAP. We stimulate this initially distally at the ulnar nerve at the wrist, then below the elbow, and more proximally above the elbow, and further sites can include the axilla and Erb's point. Conduction block is defined as a drop in that CMAP amplitude between 2 points. Now, in this circumstance, the patient had a normal response at the wrist and a significant reduction in amplitude at the elbow, below the elbow, and similar response above the elbow. And this drop in amplitude suggested that a site of injury or impairment of the nerve's ability to propagate this electrical stimuli occurred over the forearm. Conduction block sometimes is accompanied by slowing and is thought to represent a focal demyelination at that area, which is why often we talk about compressible sites, because if there's compression at the elbow, there will be a reduction in the amplitude because some fibers are not firing at all, or they're firing asynchronously. And so the importance in this case of it being located in the forearm was suggesting that it hadn't occurred at the elbow, that there was an alternate pathology occurring in that segment across the forearm.
I think that probably most people have encountered ulnar neuropathy, even if they invoked it in themselves accidentally. But could you please just remind us what the most common sites of compression are for the ulnar nerve, although it's not relevant in this particular case?
Stephen, with regards to compressible sites of the ulnar nerve at the elbow, the most common site is in the cubital tunnel, as the ulnar nerve runs through the cubital tunnel. Other areas of entrapment can include in the arcata struthers, which is a little further proximally up the arm, and rarely in the forearm at the exit of the cubital tunnel. So in some cases, neurophysiologically, this is confirmed by inching studies where the probe is moved, 2 centimeters proximally or distally to determine the site at where that drop-off occurred. So, and then can be confirmed using imaging studies, either ultrasound or MRI.
Oh, thank you for that perfect segue. So we're now going to proceed with some investigations. So ultrasonography of the ulnar nerve was unrevealing, as was MRI and FDG PET. And they've had multiple cerebrospinal fluid or CSF examinations on day 10 and 15 after chemotherapy. And this has been largely unrevealing with a normal protein, negative flow cytometry, normal cell count, and their serological tests have been unrevealing, including an anti-neuronal antibody panel. So how does this information help your diagnostic formulation? Are there particular diagnoses that you think you can now almost exclude? I know that there's going to be options left though, and we'll arrive at one of those shortly.
Yes, Stephen. So the testing thus far, or at this point in time, as you've mentioned, had been relatively unenlightening as to what the underlying etiology of these neuropathies were. Importantly, though, there was concern. This was a man who had received, new or induction chemotherapy regarding infection, whether it be bacterial or fungal. The fact that the repeated CSFs were normal made that less likely, and we were able to take that off the table as one of the differentials. Similarly, repeated negative antineuronal antibodies and serum antineuronal antibodies made a paraneoplastic phenomena less likely. Though these initial CSFs were negative, the potential still for CNS and PNS involvement of the underlying leukemia was still a possibility. And they can, as the literature has suggested, they can be notoriously difficult to identify on CSF, both lymphoma and leukemia. And sometimes up to 3 large volume taps are required to identify blasts or abnormal cells.
Well, in that context, just as you've suggested, a third cerebrospinal fluid sample was obtained. This was obtained on day 24, and this did confirm the presence of myeloblasts, and this is consistent with central nervous system infiltration with leukemia. And this led to a presumptive diagnosis of neuroleukemiosis. Now, Dr. Triplett, I think one of the first times I ever encountered this diagnosis was when you told me about it on the ward. Neuroleukemiosis may be a new diagnosis to some of our listeners. Could you please just tell us a bit more about the diagnosis?
Yep, certainly. So neuroleukemiosis is the infiltration of leukemic cells into peripheral nerve sites. It's a rare condition with probably around 45 to 50 cases described in the literature. The condition is thought to occur due to spread of these leukemic cells that then interact and alter the blood-nerve barrier, allowing them to enter the peripheral nervous system itself. And this basically becomes a sanctuary for leukemic cells. And they thus replicate, cause further damage to the peripheral nerves. Cases that have occurred in the past have been either multifocal in nature with a large or a significant painful component to them, suggesting a vasculitic component, where other cases have been almost a fulminant presentation mimicking Guillain-Barré syndrome or inflammatory polyradicular neuropathies. Though it's rare, it generally portends a poor prognosis for patients because the cases reported thus far have either occurred in the setting of relapse or in the setting of poor cytogenetics. And diagnosis for this condition can be difficult, and often CSF on its own is insufficient to make a diagnosis. And in some cases, a nerve biopsy is required. Obviously, in this circumstance, there was no easily biopsiable site, and eventually a CSF did return positive. But to put that in perspective, in a literature review of the previous cases, the initial CSF was only diagnostic in a third of cases, and became positive on serial testing in around a total of 50% of cases. So the remaining cases were diagnosed either from nerve biopsy or were presumptive based on other conditions being excluded. Once diagnosed, though, it is important that it often leads to escalation of treatment or the commencement of intrathecal chemotherapy. And in some cases where there's a single lesion or single nerve involved, there may be focal radiation or surgery considered. In this case, obviously, the changes in treatment, etc., were managed by the haematology team, with the neurologists taking a back seat.
Right. So in this case, as you've described, treatment was escalated with intrathecal cytarabine and methotrexate in addition to the intravenous escalation of therapy. And this did lead to clearance of the central nervous system blasts. And this was within a week. And then subsequently there was resolution within 2 months of the neuropathies. Unfortunately, later in the patient's course, they did relapse and subsequently died as a result of their leukemia. Now, this is a sad outcome from what is a very serious illness. However, the case does provide us with an opportunity to learn about a neurological manifestation of a systemic illness, which has treatments. The treatments enabled this patient to have resolution of their neuropathies for a period of time. So it's a very valuable case for all of us to learn from, and we're thankful to the patient and their family for sharing it. So, Dr. Triplett, what do you think are the key take-home points from this case?
So, Stephen, I think there's numerous points from this case. The first and foremost is that patients with hematological malignancy of any kind, can develop neuropathies and neurological sequelae from a multitude of reasons. The first being, as in this case, it's direct malignancy. The second, that it's treatment associated, or third, that it's a paraneoplastic phenomena. So I think we have to keep an open mind when a patient who is either being worked up for an initial malignancy or is thought to be in remission from their condition starts to develop new neurological symptoms. This case in neuroleukaemiosis is obviously a rare condition, and I would assume that it's been underreported over the years. But again, the presence of in a patient with leukemia at the time, efforts should be made to confirm the diagnosis in as timely manner as possible. And as mentioned, that may require multiple high-volume CSF analyses. The first CSF being normal exclude malignancy. It often requires the input of multiple specialties, obviously the haematology team and neurologists, but also input from radiology colleagues in regards to the optimal ways of trying to assess for metastatic spread, either via PET scan or, in this circumstance, trying to identify areas of nerve infiltration using ultrasound or MRI. And finally, the presence of neuroleukaemiosis should lead to consideration for escalation of therapy. In a more broader aspect, as opposed to this case itself, I think it is important, and it is a good teaching case to discuss the potential causes of third nerve palsies and also of mononeuritis multiplex or multifocal motor neuropathies, which do again have a relatively broad differential, though all of which often require acute treatment.
Thank you very much for joining us, Dr. Triplett. This has been a very educational case for me, and I hope for our listeners. So if they'd like to learn more, the original article was titled Painless Progressive Mononeuritis Multiplex, Secondary to AML-Associated Neuroleukaemiosis. It's published in the Journal of Neuroimmunology in 2023, and the senior author was Dr. James Triplett, who's joined us today. Thanks again, Dr. Triplett.
Thank you very much, Stephen. Thank you for the opportunity.
Thanks again to Stephen Bacchi for coordinating this case report. He's done this on top of a whole host of other responsibilities, so please don't hold this podcast up as the authoritative clinical textbook. These case reports are mostly intended to demonstrate a structured approach to diagnostic reasoning and case presentation. Also under the Pomegranate Health banner are our Journal Club discussions, our IMJ on-air interviews with authors of the Internal Medicine Journal, and our classic documentary episodes on the culture of medicine. Please ask your friends to subscribe by searching for Pomegranate Health in any podcasting app, or by joining the email alerts list at our homepage. If you've got ideas of other stories we should dig into, please send an email to podcast@racp.edu.au. I'm keen to hear from both fellows and trainees, and I'm always thrilled to find out how diverse our audience is. Every episode gets downloaded around 6,000 times over its first year of availability. While 79% of listeners are located in Australia and Aotearoa New Zealand, the remainder are split evenly between the obvious English-dominant countries and the rest of the world. RACP members also have access to other online resources at the website elearning.racp.eu.au. Of particular interest to basic trainees is the College Learning Series, or CLS. There are separate streams for adult and paediatric medicine, which each have hundreds of clinical lectures tied directly to the training curriculum. In fact, if today's podcast whetted your appetite, there are recently added lectures on peripheral neuropathy and acute myeloid leukemia. This podcast was produced on the lands of the Gadigal clan of the Eora Nation. I pay respect to the custodians of this country who came before me. I'm Mick Cavazzini. Thanks for listening.